שלום לכולם, צהריים טובים. בדרך כלל, קודם כל, תודה רבה להאווי והאיגוד רפואיים פנימית בארץ על ההזמנה להיות פה, אני ממש מעריך את זה. ובדרך כלל בפרזנטציה אקדמיה זה ממש חשוב להגיד אם יש לך ניגוד אינטרסט לפני אתה מתחיל את ההצגה. ואני חייב להגיד, יש לי ניגוד אינטרסט מאוד מאוד גדול. האמת, אני רוצה להיות טייס, לא רופא, ורציתי להיות טייס, לא רופא, ואני רואה עצמי יותר מטייס רופא, ורוב העבודה שאני עשיתי את כל השנים במכשירים הנשמה, היה פשוט לעשות מכשיר הנשמה יותר טוב למטוסים, לעשות העברות של חולים בטיסות דרכות מדרום אפריקה, שהיה לנו צורך להביא תינוקות לדרום אפריקה, לפרופסור ברנרד לעשות ניתוחים לב לתינוקות. היה בעיה רציני להביא כל האוויר למכשירים בשנים האלה שהיה צורך לחמצן וגם אוויר דחוס, והיה בעיה רציני. עם יהודי מירושלים, אני עשיתי קשר מירושלים לניופורט, לזאת הברית, ובנינו את המכשיר הראשון של הנשמה להעברות חולים במטוס, קוראים את זה ניופורט HD50, ויש לי אצלנו עכשיו אדון רוברט ברינק, שהוא היה לפני 36 שנים הסטודנט אצלי לטכנאי הנשמה במחלקה, ואני חייב להביא לאנגלית שהוא מבין מה אני הולך להגיד על המכשירים שבנינו. So welcome to Robert Brink from IMT Switzerland, who's been with me for 36 years, and we've worked on a number of ventilators which became famous worldwide, most particularly the Newport HD50, which was the first ventilator that was able to transport people a long distance on air ambulances, and it was a development after the flight ventilator from our Air Force, which was designed by a guy called Melly in Jerusalem, and I connected them with Robert Brink with the Newport company because we were using Newport ventilators in South Africa at that time. And that became a product of thousands of sales in the United States for transport. And the only reason I'm a doctor is because when I was accepted to the South African Air Force as a pilot at the age of 17, when I had already a private pilot's license, my father refused to sign the documents that signed me on for 7 years. He said, go to the university and bring me some kind of paper that you can earn money so you can pay for your flying. And I said to him, okay, what must I do? And he said, well, the only thing I know that can give you a job anywhere in the world is nursing and being a doctor. And there's no way I was going to be a nurse. So I went to do medicine, and that's the reason I'm a doctor. Because my father wouldn't sign the papers. I was accepted to the Air Force. I had to sign on for 7 years, and he would not sign, so I had to be a doctor. So I said, what kind of doctor I must be? A surgeon. So I thought, well, I'll do surgery, make most money. I did it for 2 years, didn't like it. Then I thought, well, gynecology, 2 years, I didn't like it. Then I decided I liked critically ill patients, and I went to intensive care. Long story, but that's the facts. So I want to tell you about a little bit of why I think what we're doing in ventilation is so much related to aviation. If we look at the dangers that we're exposed to as human beings, there's some things that we do that are very, very dangerous, like bungee jumping. I mean, anybody that's crazy enough to do a bungee jump is really terrible, but that's the most dangerous thing we can do. The second most dangerous thing is drive a car, not as bad, and the safest thing we can do is fly internationally on airlines or go on the trains in Europe. That is the safest way to travel and one of the safest things you can do to enjoy life. Where do we sit with medicine? Sadly, in a very dangerous, precarious situation for events that lead to death. I love flying, and this is the aircraft we fly here in Israel as an air ambulance. And I want to talk about what we can learn from aviation and use it and apply it to medicine in AI. This was the aircraft I flew in South Africa for I've been flying air ambulance aircraft. This is what I flew in South Africa for 10 years. I've been flying for 40 years, and I've learned a lot in aviation. That's the cockpit of the Citation 2 that I used to fly. And you can see that there's a lot of round dials and things that you have to collect. And you have to integrate the information, interpret the information before you can evaluate and decide what to do. Today, it's become much more advantageous to have, with AI and technology, things like the Garmin flat screen, which give you, as you can see, a very nice picture of what you're seeing, the sky, the ground, and where you are, and all you have to do is evaluate and decide. You don't have to interpret, detect, and see what's going on. It's what we call situational awareness. What makes commercial aviation so safe? Firstly, you have improved situational awareness. Every pilot knows exactly where you are, what you're doing. He's watching the autopilot and he's doing. And you've got appropriate automation with the autopilot. And when pilots were first introduced to the autopilot, they said, no, well, I can fly the aircraft much better than the autopilot. And we've proved that wrong, because no pilot today believes he can fly better than an autopilot. And the minute you take off at Ben Gurion Airport, a few seconds into the flight, you're on autopilot all the way to land in the United States, and that's why it's so smooth and comfortable and safe. You have to have the reliable equipment installations, and you have to have, of course, advanced crew training. And simulators today in aviation are the reason that aviation is so safe, because in the simulator you can show what could happen, you can practice, and you can fly. Most pilots that get into an airline get into the first flight with passengers after being in a simulator, never flying that aircraft before. Because all is done in the simulator is much more precise, complex, and stressful than flying the aircraft. And I was lucky to be able to go to simulators in the United States, in Dallas, on the Citation aircraft, and I know exactly what's the difference between the simulator and flying the aircraft. You get into the simulator, you're scared as hell, things go wrong, they fly emergencies at you. When you get into the airplane, it's a piece of cake. When you're coming in to land at Ben Gurion, that's what you see. Look how precisely you can see exactly where the sky is, where the ground is, what your altitude is on the right, what your rate of descent is, what your speed is, what's the maximum speed you can fly at the top left, what's the height you're aiming for, and you can fly down the glide slope and land without any trouble, mostly on autopilot. But the situational awareness of where you are makes it very easy to make any decisions, and you're not stressed. If we look at the insight into medical errors, the dominant contributing factor to patient death on ventilators was inadequate orientation of what was going on and inadequate training. So I thought that maybe what we should do is look, what will make mechanical ventilation safe? And that's what I've been doing for some 30 years, starting with the Hamilton company in Switzerland. Stephen Hamilton, the owner of the company, is a personal friend of mine. He's also a pilot. And we worked together to develop the first automated ventilation, which I'm going to tell you about. So improved situational awareness on the ventilator, appropriate automation, and I'm going to talk about the AI mode. In fact, 30 years ago, we were already developing the AI mode, but for the FDA, the FDA and the authorities, we never mentioned it, because the minute you mentioned automation, no, we need more tech, more things, so we didn't mention it at all. But AI at its best, we started working on 30 years ago with reliable ventilators and started advanced training methods. When you look at some of the ventilators we see in Israel today, and I now travel around after leaving the ICU in Hadassah some 10 years ago, I've been going around to hospitals all over the country, to the medical wards, and that's the kind of thing you see on the ventilator. It's very difficult to know where you are, what the orientation is, and what's happening with the patient. Today, the situational awareness is much better. Now, in the medical ICU in Hadassah, some of you may know that about in 1998, we put into Hadassah the first completely automated autopilot ventilator with a Hamilton Galileo, the first unit in the world with automation of ventilation, with a Hamilton Galileo ventilator. And for 10 years, we used the ventilator almost solely in automatic mode with what we called ASV, or adaptive ventilation, which was my research project for some 40 years. If you type into Google adaptive ventilation Lynton, you will see all the publications. I haven't got time to go into all of them, but I want to show you that that's what it looked like, and it's what we call situational awareness. I published in the publication after 10 years of using it, adaptive support ventilation as the sole mode of ventilatory support in chronically ventilated patients. When I came to Israel in '96, there was not a single Hamilton ventilator in the country. I brought the first one, and when I presented to the Aigud Tiful Nmratz my research work, Everybody told me this was science fiction. It would not work. You have to know what you're doing and have to control the ventilator. Automation will not work in ventilation, and we've proved them wrong. Every intensive care unit in Israel right now has Hamilton ventilators. What was the secret? The secret was the ingenuity of a guy called Joseph Brunner, Professor Joseph Brunner, who worked with a guy called Wolf and published the first book on measurement of lung function, not in the lung function laboratory, that you could measure lung function online with a flow sensor. The flow sensor has got a diaphragm, 2 pressures. It measures every parameter of inspired air and expired air, pressures, flows, time constant of the lung, any parameter you can measure in the lung is measured by the flow sensor, goes into a computer, and the prototype we had in South Africa that we researched was a PC with a Macintosh computer driving the Hamilton Amadeus ventilator. That was the prototype. We did the original research, and that was the start of automation in ventilation worldwide. What is the principle? The principle is the flow sensor in the bottom right measures those parameters. It puts it into the lung function analyzer, which has got the algorithms that we wrote. It goes into a selector, and the doctor puts in the target tidal volume for the patient according to his height and weight, and the target oxygen concentration and PP1s, and the automatic controller controls only 2 parameters, rate and volume. And if the patient needs a higher volume, it gives it, lower volume, it gives it, in the faster rate and lower rate. Because in certain diseases, you need a faster rate and a slower rate. And whatever you do, it gives an ideal parameter, and you get the best blood gases at the end of the ventilation. We had to, of course, put some lung protective rules, because everybody says this is dangerous if you have an autopilot machine. So we had to have protective rules for certain cases with bigger tidal volumes and lower rates. And for certain diseases like stiff lungs, we had to have lower pressures and faster rates. So for obstructive lungs, you put a safety measure in that does not allow high frequency. And for restrictive lung disease, pulmonary edema, low lung compliance, you put in a restrictive, which does not allow high tidal volumes, which we call baby lung or protection, that you give smaller tidal volumes at a slightly faster rate to get the same blood gases. Because you can change CO2 by increasing rate or volume. But some cases in patients, you have to give a low volume with a higher rate, and some with a higher volume and low rate, depending on the lung disease. But basically, with the new ventilators we developed, now we have the Bella Vista, which you can see outside, and I've been using it now in Israel for 10 years. We developed it some 50 years ago with Robert Brink in the IMT company in Switzerland, and you're able to put in the parameters you want according to the height and weight, and you select an oxygen, a P level that's correct, and then the machine stands ready. All the staff have to do when the patient arrives is connect the patient, put start ventilation, and the automatic system goes. And the ventilator will control the ventilation. It will allow movement between modes of full ventilation right down to spontaneous breathing with CPAP. No adjustment of mode or name of mode is needed by the doctor. We call it adaptive ventilation, and it's completely automated. As the patient's work of breathing increases, so the ventilator reduces its work of breathing, and so the patient transitions from full ventilation to spontaneous ventilation as he wants, when he wants. During the day, he may be breathing spontaneously by himself, and at night he may need the support. When he lies down and he sleeps, he may need the support, but it's completely automated. This is not a mode of ventilation, it's a philosophy of control of all the ventilation modes. And we use pressure, volume, pressure support, pressure controlled, pressure limited, all together in all the modes, moving from back and forth as what the patient needs. So you'll come in and the patient may be breathing spontaneously, or you'll come in and fully ventilated, but the patient will be comfortable. And what's the most amazing thing? You do not need to sedate the patient. If you come and see our patients in the chronic ventilatory centers, and I started the first one in Herzog, and then we went to Ashdod, and we set up the first automated ventilation weaning in Ashdod at Beit Hadar, and I published it in Chest also, that we had patients and we managed to wean them within a very short time, even though the Ministry of Health said the patients had to be in hospital with 3 trials of ventilatory weaning and at least 3 months of attempts before they could come. We meet 30% of the patients in the first month, and we continue year by year with the automated ventilation to wean 30% of our patients that we get from all the ICUs in the country to all the centers we have these ventilators. Now, when we come to weaning off the ventilator, this is always a big headache for people in the wards that are looking after patients after ICU. Well, it's completely automated. The whole weaning process is completely automated, and I published in Chest automated weaning from mechanical ventilation even before I came to Israel with the prototypes, and we showed that you could wean the patient automatically, safety, on the automatic ventilation. You know that you can predict the weaning possibility of any patient by measuring the RSB, the Rapid Shallow Breathing Index. If you take the tidal volume of every patient, you take the respiratory rate of every patient, and you divide it by the tidal volume in liters per minute, you get a number, and you can say for sure if the number is lower than 100, you can say the patient is likely to be weaned. If the number is lower than 80, you can be guaranteed they will wean. If the number is more than 120, the patient is not likely to wean, and it's based on what we call the Rapid Shallow Breathing Index, because most people that go into respiratory failure by a rapid, shallow breathing pattern. That's what happens. Unless you get hit on the head or you get a sedation or paralyzed and you stop breathing, most people that get pneumonia, pulmonary edema, COPD, go into respiratory failure by a rapid, shallow breathing pattern. And that's the secret in predicting the wean and knowing what's going to happen. So what we have is we have a graph of the minute ventilation, which is that green line, and on the minute ventilation at any position there's a tidal volume and a rate which is optimal for that patient, for the mechanics of breathing, of his physical size and the size of his lungs. And all we have to do is see what the patient is doing. Now there are factors that increase the workload, and there's factors that increase the ability of the patient, because if a patient can wean or not depends entirely on what the demand is and what he can provide. So what will increase the workload? There's a whole list of factors that will increase the workload: increased airway resistance, increased chest compliance, and increased lung load. And there are certain things that reduce the patient's ability to wean. He may have decreased drive from some neurological reason, from some central nervous system reason. He may have muscle weakness. He may have neuromuscular weakness. But it doesn't matter. If you put the patient on the automatic ventilation, it will tell you what's happening with the patient and why he's not weaning and help him to get to the weaning. So we have what's called the cockpit. I called it a cockpit for some special reason, because in the pilot, we have a cockpit and we see in the cockpit what's going on. And I designed this cockpit for the Bella Vista ventilator, which you can see outside. And with a picture like that, I can tell you exactly what's going on with the patient, what his compliance is, what his resistance is, what's the pressure the ventilator has to give him, what his space of weaning. You'll see the curve in the top left. The white dot is the target of the ventilator, will not allow the patient to go with a lower tidal volume or a lower rate. If the patient is the blue dot and he's above the curve, he's either doing a higher tidal volume or a higher rate, and his blood gases will be good, and you can take him off the ventilator. And you can see in the top, in the middle, there's the pressure support of 5. It means the patient is only getting 5 centimeters of pressure support, spontaneously breathing by this ventilator, because that's all we need to overcome the resistance in the circuit, and the patient breathes spontaneously. All we have to do is decide how much oxygen he needs, and with a pulse oximeter, you can check that non-invasively. For 10 years, to start with at the Gולדנקייר Center on this ventilator, I did never do one single arterial blood gas. Not one single arterial blood gas.
יש לנו דקה אחת. 1 minute.
It's finished in 1 minute. Okay? Not one single arterial blood gas. Why? Because if you ventilate the patient mechanically, according to the requirement of the lung, the arterial blood gases will come out as best you can. And why do we know this? Because the company built the LVO lung simulator, and we put all the II of every lung disease into the simulator, and it can simulate severe bronchospasm, mild bronchospasm, asthma, COVID lung, ARDS, pulmonary edema, and it can simulate the patient's diaphragm, how much effort he's giving, and fight the ventilator. And the LVO you can see outside, that is the secret behind the AI of the new ventilator. So the box project is our final project now, because I decided I needed a ventilator like this for people at home, because I go around the country and I see people at home on ventilators, and I'm horrified that I see patients years, months, years on ventilators that should not be on ventilators, and when we put them on the Bella Vista in the center, we managed to wean them, and it shows they should never have been on the ventilator all this time. So the box is the new project. The beauty of the box, it's going to be 10 times the computing power and capability of the Bella Vista. It's going to be much cheaper. It's going to be 1/3 of the price of any other comparable ventilator, and it's going to be available. And not only is it going to be available, we are going to make it in Israel. We're setting up the production line in Jerusalem, and we're going to bring in the parts in, and we're going to build a ventilator to give Israel the cheapest mechanical ventilator for out of ICUs, in the medical wards, at home, on ambulances, and in the aircraft. This is the final story. What we have is what we call the SMART mode by AI on the box ventilator. SMART stands for synchronized, mandatory, adaptive respiration therapy by AI. And what we will do, we will provide with every single patient automatically optimal alveolar ventilation, because that's the goal, for the lowest possible minute ventilation, because you don't want to overstretch the lungs, for the lowest possible dead space, with the optimal rate of breathing and the optimal IE ratio. The IE ratio is the secret between success in weaning, because that's one parameter that is very badly set from physicians around the world. IE ratio is the critical parameter of what you need. In a patient with stiff lungs, you need an IE ratio of 1:1 or less than 1, inverse ratio. For a patient with asthma or COPD, you need an IE ratio of 2, 3, 4, 5, 6, or even 7. And this machine does it all automatically. Whether the patient gets the bronchospasm, it will give a long IE ratio. If the patient gets bronchodilatation recover, it will give a less, and it will wean the patient. So we provide it with completely automated weaning with an absolute minimum need for parameter input. All you have to put in is the oxygen concentration based on the pulse oximeter. No need for CO2 analysis, no need for blood gases. The patient, if he's awake and he's weaning and he's breathing, he's getting the blessed blood gases. Thank you very much.
Thank you very much.